Welcome to PRISM Rounds, an audio journal club built for busy clinicians who want the bottom line, the nuance, and the bedside relevance of the latest critical care evidence. I originally started making these episodes for my own learning and review, and I'm glad to share them with others who may find them useful. If you enjoy the show, please follow or subscribe to help support the podcast and stay up to date with future episodes. This podcast for educational purposes only, not medical advice. Thanks for listening.
Right, so we have a massive topic today.
We really do. I mean, for the last 20 years, the dogma has basically been to just flood the septic patient with fluids, right?
Yeah, flood them and blast them with broad-spectrum antibiotics the absolute second they hit the door.
Exactly. But today, we're doing a deep dive into why doing exactly that might, well, actually be causing profound harm to a huge subset of your patients.
Because we are unpacking the 2026 Surviving Sepsis Campaign Guidelines, and honestly, the rules of the game have officially changed.
It's wild. It feels like a total philosophical shift at the bedside.
It is a phenomenal shift, really. For a long time, sepsis management felt like this rigid, unthinking assembly line.
Just checking boxes for the hospital administration.
Right, they wanted the bundle checked off, and we complied.
Right.
But these new guidelines represent a real maturation of the field.
So we are moving away from that strict, protocolized care.
Exactly. We are officially transitioning to what they are calling precision-informed resuscitation.
Which means we are finally acknowledging the actual complexity of the human body.
Yeah, treating the patient, not the protocol.
But before we get into the granular bedside changes, let's just ground ourselves and why this single document matters so much to all of you listening.
The global footprint of this disease is just, it's still almost impossible to fully comprehend.
The numbers are staggering. We're looking at, what, almost 50 million cases?
An estimated 49 million cases of sepsis worldwide every single year. It is massive.
And despite all our shiny new ICU tech, the mortality is still terrible.
Yeah, sepsis still claims roughly 13 million lives annually. It is the leading cause of death in hospitals.
The leading cause of readmissions, too.
Right, and one of the most significant healthcare expenditures on the planet.
And what's wild to me is that after billions of dollars in research, we still don't have a magic bullet.
No, there's no single molecular cure for sepsis because, well, sepsis isn't a singular disease.
Right. The 2026 guidelines really reinforce that sepsis 3 definition.
Exactly, reminding us that it's a life-threatening organ dysfunction caused by a dysregulated host response to infection.
So you aren't just fighting the bacteria. You're fighting the patient's own catastrophic inflammatory cascade.
Yeah, and since we don't have a magic bullet to just, turn off that cascade, survival relies fundamentally on our clinical workflow.
It relies on how fast we recognize it.
Exactly, and how flawlessly we execute the basic systems of care. So let's start at the front lines.
The recognition phase, because obviously you can't treat what you don't recognize.
Right. And the workflow always begins with screening, which brings us to the first major controversy addressed in this update.
Oh, this is a big one. You're talking about the quick SOFA score.
Yes, the quick SOFA score. Remember when the sepsis 3 definitions introduced it?
Yeah, it was supposed to be this rapid bedside tool to identify high-risk patients outside the ICU.
Exactly. It looked at 3 simple variables: altered mental status, a respiratory rate greater than 22, and a systolic blood pressure less than 100.
If you had 2 out of 3, the alarm bells were supposed to ring.
But the new 2026 guidelines are explicitly recommending against using the quick SOFA score as a single screening tool.
Which makes sense. I mean, a quick SOFA score is basically like a smoke detector that only goes off once the roof is already caved in.
That is a perfect way to conceptualize it.
Right. Like, if a patient is altered, breathing 30 times a minute, and hypotensive, any intern walking down the hall knows they are sick. We don't need a score for that.
Yeah, mathematically, it's excellent at predicting mortality or a prolonged ICU stay.
But for actually screening undifferentiated patients,
Its sensitivity is notoriously poor. It misses the smoldering infections.
like the patient brewing a severe pyelonephritis, but they're currently compensating with a heart rate of 110.
Right, while their blood pressure is still holding on, it requires the patient to be actively failing in order to flag them.
Which leads to a massive number of false negatives early on. And in sepsis, diagnostic delay is literally death.
Precisely. We need a screening tool that casts a much wider, more sensitive net to catch that subtle early drift.
So if we're throwing the quick SOFA score in the bin for primary screening, what does the Surviving Sepsis Campaign actually recommend we use tomorrow?
They now strongly recommend relying on established early warning scores.
Like the NEWS.
Yeah, the National Early Warning Score, or its updated version, New WS2. They also validate using MUWS or even the classic SIRS criteria.
Wait, let's talk about the SIRS criteria for a second, because that feels like a total blast from the past.
It really does, yeah.
We spent years vilifying SIRS for being too nonspecific. I mean, anyone jogging up a flight of stairs meets criteria for tachycardia and tachypnea.
Right, but in the context of screening, high sensitivity is actually your best friend.
So you want the false positives.
Well, you accept them. Because SIRS and the National Early Warning Scores track variables like temperature derangements and subtle hypoxia.
So an automated algorithm analyzing the electronic health record flags it as subtle trend earlier.
Exactly. It's much better at catching the pre-shock patient than waiting for them to become encephalopathic.
Okay, so the system flags the patient. But an alert firing into the void of a busy emergency department doesn't save a life.
No, someone actually has to do something, which is why the guidelines try to bridge the gap between electronic screening and human action.
Right. They strongly recommend that hospitals implement formal performance improvement programs.
Specifically highlighting the code sepsis or bedside sepsis huddle.
Walk me through that. Because alert fatigue is real. You get a pop-up every 5 minutes and you just click ignore.
Yeah, a true sepsis huddle completely bypasses that passive electronic alert fatigue.
How so?
When the screening criteria are met, an active, multidisciplinary team physically converges at the patient's bedside within minutes.
So it's treated with the same operational urgency as a stroke alert?
Or a trauma activation, exactly. It forces real-time, synchronous communication.
So you have the primary nurse, an advanced practice provider, maybe a clinical pharmacist, all in the room looking at the patient.
Right. The provider can instantly assess perfusion. The nurse gets large bore access.
The pharmacist pulls the correct weight-based antibiotics.
And the data shows this coordinated response significantly reduces time to antimicrobial administration.
It creates instant diagnostic momentum. But the guidelines also emphasize that this shouldn't just start at the hospital doors, right?
No, there's a huge new focus on the pre-hospital environment.
Like EMS and flight crews.
Yes, a new suggestion emphasizing standard sepsis screening in the field.
So if paramedics are evaluating a nursing home patient with altered mental status and a fever, they don't just transport blindly.
Exactly. They should utilize standardized screening tools, draw pre-hospital lactate levels if they have the devices, and call in a sepsis alert over the radio.
That way the receiving hospital has the fluid bag spiked and the antibiotics primed before the patient even arrives.
It shaves critical minutes off the resuscitation timeline.
Now, while we're talking about making the diagnosis, we have to touch on biomarkers.
Ah, yes. The Holy Grail.
Every time I talk to an infectious disease specialist, we debate lab values. Everyone wants a singular blood test to rule sepsis in or out.
Like a troponin for a heart attack?
Exactly, or a D-dimer. But that test just doesn't exist yet, does it?
It really doesn't. Sepsis remains a fundamentally clinical diagnosis.
It requires a human to synthesize the history, the physical exam, the vital signs.
Right. And what about all the novel rapid host response diagnostics? Transcriptomics, things like that?
Yeah, what's the verdict there?
The guidelines are clear. There is currently insufficient evidence to recommend using them to rule sepsis in or out.
They might be interesting research tools, but they aren't ready for prime-time decision-making.
Exactly.
And what about our old friend procalcitonin?
Oh, procalcitonin has completely fallen out of favor for that initial triage phase.
We used to check it constantly to figure out if respiratory failure was bacterial or viral.
But the 2026 update explicitly suggests using your clinical evaluation alone rather than relying on a procalcitonin level.
Because waiting 2 hours for that lab to result while a patient is hypotensive is incredibly dangerous.
And even a low procalcitonin doesn't definitively rule out a localized bacterial infection anyway. You treat the patient, not the biomarker.
Okay, so the code sepsis triggered. We suspect a severe infection. This moves us out of recognition and into the crucial first hour.
The immediate reflex is to draw labs and hang the antibiotic bags.
But the golden rule hasn't changed. You must obtain blood cultures before giving any systemic antimicrobials.
Because even a single dose of broad-spectrum antibiotics can completely sterilize the bloodstream.
Leaving you with negative cultures, flying blind for 2 weeks, unable to de-escalate.
But, and this is a massive caveat in the Surviving Sepsis campaign.
You never, ever delay life-saving therapy just to get cultures.
Exactly. If you have a patient with difficult vasculature or phlebotomy is tied up, and you can't get cultures within, say, 45 minutes.
You just give the drugs.
Yes. The theoretical benefit of knowing the bug tomorrow does not outweigh the real risk of the patient dying today.
Alongside those cultures, what's the other mandatory blood test in that first hour?
You absolutely must measure a baseline blood lactate immediately.
Why is lactate so critical right then? We check it constantly, but what's the physiological truth it tells us?
It helps us identify occult sepsis-induced hypoperfusion.
Right, because a patient can have a totally normal blood pressure.
Exactly, because their sympathetic nervous system is in overdrive, maximally constricting their arterioles to hold the pressure up.
But because those arterioles are clamped down so tight, the capillary beds feeding the brain and kidneys are starving for oxygen.
Yes, the tissues switch to anaerobic glycolysis, which generates lactate as a byproduct.
Plus, the inflammatory cytokines directly impair pyruvate dehydrogenase, driving even more lactate production.
So a lactate level greater than 2 millimoles per liter serves as an early, bright red flag that the cellular machinery is failing.
Even if the macrohemodynamics look falsely reassuring.
Right. Okay, so cultures are drawn, lactate is pending. Now we arrive at the antibiotic clock.
This is probably the most heavily scrutinized section of the entire 2026 document. It's a massive paradigm shift.
It really is. The old dogma was simple but reckless. Hit hard, hit early.
Meaning blast absolutely every suspected patient with broad-spectrum antibiotics within 1 hour.
But the pendulum has swung back. Treating every mild fever with an instant hammer carries immense collateral damage.
Antimicrobial resistance, severe C. diff, acute kidney injury from vancomycin.
So the new guidelines balance this urgency using a highly nuanced matrix.
The timing now depends on two things, right? Shock and diagnostic certainty.
Exactly. Let's walk through the matrix. Say Mr. Davis comes in. Cough, fever of 102, blood pressure is 70/40, lactate is 4.5.
He is in clear shock.
If shock is present, the clock is uncompromising. It doesn't matter if sepsis is definite or merely possible.
If the cardiovascular system is actively collapsing, you administer broad-spectrum antimicrobials immediately, within 1 hour.
There is zero debate there. You shoot first and ask questions later.
Okay, scenario 2. Mrs. Smith from a nursing home. Normal blood pressure, lactate is 1.1.
But she has a roaring fever, a Foley catheter filled with pus, and a white count of 25,000.
So shock is absent, but the infection is definite or highly probable.
You still administer antibiotics immediately, aiming for that 1 hour window to prevent her from progressing into shock.
But here's the bombshell. Scenario 3. Mr. Henderson, 72, history of heart failure.
Comes in feeling weak, mild temp of 99.9, heart rate is 105, blood pressure is fine.
He might have a viral infection, early heart failure, or a bacterial pneumonia. The diagnosis is only possible.
In the old era, he would have received an immediate massive dose of IV vancomycin and cefepime within 60 minutes.
Just to satisfy the bundle metrics.
Yeah.
Wait, take a breath here. For a decade, I was told every minute delay increases mortality by 8%.
I know, it feels like a legal and clinical risk. But that 8% statistic was primarily derived from patients already in profound septic shock.
Oh, wow.
For stable patients like Mr. Henderson, the risk of rushing to broad-spectrum drugs actually outweighs the theoretical benefit.
So what are we actually doing during that delay? We get up to 3 hours.
Yes, there's a safe 3-hour window.
Yeah.
And you aren't sitting around drinking coffee.
You're performing a rapid, intensive clinical assessment.
Active hunting for diagnostic clarity. Point-of-care ultrasound for B-lines versus consolidation. Checking a viral panel.
Acting as a true diagnostician again, not a robot checking a box.
Exactly. If you find severe pulmonary edema, you withhold antibiotics and treat the heart failure.
But if the concern for infection persists, then you commit and give the drugs.
Right. It's brilliant stewardship. Now, if we do give the antibiotics, there's a strong recommendation on how to administer beta-lactams.
Drugs like piperacillin tazobactam or cefepime, the guidelines say use prolonged infusions, right?
Yes, prolonged infusions over traditional short bolus administration.
Normally, a nurse runs it in over 30 minutes. You're saying we drip it in slowly over 3 or 4 hours.
It comes down to pharmacokinetics. Beta-lactams are time-dependent killers.
They don't care how high the peak concentration gets.
Right. They only kill bacteria when the drug concentration in the blood remains consistently above the minimum inhibitory concentration.
And critically ill patients have wildly unpredictable physiology. They might have augmented renal clearance, filtering the drug out twice as fast.
Or severe capillary leak, dropping the blood concentration below that threshold.
If you give a short bolus,
Yeah.
the drug spikes, then falls below therapeutic levels way before the next dose.
Exactly. A prolonged 3-hour infusion guarantees the drug continuously bathes the bacteria.
But wait, there is a major trap here we have to warn people about.
The loading dose trap.
Right. If a patient is in florid shock and you take 3 hours to drip in their very first dose,
They will be severely underdosed for those first 2 hours while bacteria multiply.
you must never start with a prolonged infusion.
Always administer a standard rapid bolus loading dose first to instantly spike the blood levels.
And then every subsequent maintenance dose is a prolonged infusion.
Right, which requires airtight communication between the physician, pharmacist, and nurse.
So fast forward 48 hours, the patient's in the ICU, cultures result. What's our obligation?
You must proactively de-escalate. Stop the broad-spectrum carbapenems or vancomycin.
Narrow it down to a sniper rifle approach based on the sensitivity.
And rethink the duration.
Mm.
The old habit of automatically prescribing 14 to 21 days is largely incorrect now.
The guidelines strongly suggest shorter durations.
Assuming clinical improvement and source control, yes.
Trials like the Clovers trial and the Balance trial showed that for most uncomplicated bacteremias, 7 days is just as effective as 14.
Shorter courses reduce toxicity, preserve the microbiome, and prevent superbugs.
But all of this hinges on source control. All the antibiotics in the world won't fix an undrained abscess.
Source control is the bedrock. You must achieve it as early as medically and logistically possible.
Ideally within 6 to 12 hours of diagnosing shock. Wake up the interventional radiologist at 2 a.m. for a drain.
Or get the surgeon to the operating room. Prolonged medical stabilization is futile if you don't turn off the tap of the infection.
Okay, so bacteria replication is stopped, source control is achieved, but their capillaries are still leaking, and they're hypotensive.
This brings us to the most fiercely debated topic in critical care history: fluid resuscitation.
Oh, the fluid wars. Back in 2001, Manny River's early goal-directed therapy mandated massive, aggressive fluids.
It saved lives by forcing clinicians to pay attention. But later trials like Process, Arise, and Promise showed those strict targets weren't necessary.
And might even be harmful. The backlash was huge. I fully expected the 2026 guidelines to abolish the 30 milliliters per kilogram rule.
But it's still there.
Why didn't they dump it?
Because it remains a pragmatic, conditional recommendation for the first 3 hours of sepsis-induced hypoperfusion.
Because these patients really are profoundly volume depleted from sweating, vomiting, fever.
And systemic inflammation causes profound venodilation, increasing their unstressed venous volume. Their tank is larger and practically empty.
So they need that initial fluid to restore venous return.
But the application is much more precise now. We aren't blindly pouring fluid into everyone.
Right, we have to talk about body weight calculations.
Let's do the math. A patient is 5'4", weighs 150 kilograms. Their BMI is well greater than 30.
Calculating 30 milliliters per kilogram on their actual body weight yields an astronomical 4.5 liters of fluid up front.
It would drown them. So the guidelines explicitly advise using an adjusted or ideal body weight for obese patients to prevent volume overload.
That's a huge bedside change. And beyond the volume, what type of fluid are we hanging?
The guidelines strongly suggest using balanced crystalloids over 0.9% normal saline.
We still call it normal saline, even though infusing that much chloride into failing kidneys guarantees a hypochloremic metabolic acidosis.
Exactly. That massive chloride load induces profound afferent arteriolar vasoconstriction in the kidneys.
You literally choke off the blood supply to the glomerulus, which drives acute kidney injury.
This was decisively proven in trials like SMART, BASICS, and PLUS-LESS.
So we use balanced solutions like lactated ringers.
Yes. But there's one very specific critical exception.
Traumatic brain injury.
Right. Balanced solutions are slightly hypotonic. In a patient with a disrupted blood-brain barrier, that can drive free water into the brain tissue.
Increasing intracranial pressure. So that if they have a severe TBI, you stick strictly to the 0.9% saline.
Okay, so we've given the initial weight-adjusted lactated ringers, but the patient is still hypotensive. The MAP is 55.
The old reflex was just give more fluid.
That reflex is completely gone. The era of blind fluid loading is over.
Because eventually the ventricles are stretched to their max. More fluid just backs up into the lungs, causing ARDS.
So how do we decide if they will actually benefit from more fluid?
We use dynamic measures instead of static ones.
Exactly. In the old days, we looked at a static central venous pressure, or CVP.
Which is like looking at a photograph of a highway. It tells you how many cars are on the road in 1 millisecond, but nothing about the flow of traffic.
Brilliant analogy. A high CVP doesn't mean fluid overload. It might just be high PEEP from the ventilator.
Dynamic measures are like watching a video of the heart's performance under physiological stress.
We want to know, if I increase venous return, will the stroke volume actually increase?
And we test that with a passive leg raise maneuver.
You lay the patient flat and elevate their legs to 45 degrees,
You're giving them a temporary autotransfusion of their own venous blood from their legs.
while continuously monitoring their cardiac output with an arterial line or bedside echo.
If their stroke volume jumps up by 10%, they are fluid responsive. You can safely give more lactated ringers.
But if it doesn't change or drops, giving more fluid is actively harmful, you must immediately pivot to vasopressors.
What about the overall ICU fluid strategy? The liberal versus restrictive debate.
The Clovers trial randomized patients to a restrictive strategy, early pressors withholding fluids, versus a liberal strategy.
And it showed absolutely no difference in 90-day mortality.
Right, which is why the guidelines issue an either recommendation for subsequent fluids. You tailor it to the patient.
So if they have severe ARDS, you lean restrictive to protect the lungs, accepting a slightly higher risk of kidney injury,
But implementing a restrictive strategy means starting vasopressors earlier.
which usually requires an ICU bed. If you're in a full community hospital, a slightly liberal approach on the ward might be your only safe option.
That's a perfect bridge to our next topic. If the tank is optimally full, the next step is initiating vasopressor.
We have to squeeze the dilated pipes. The reigning champion hasn't changed, right?
Yeah. The guidelines emphatically confirm that norepinephrine remains the absolute first-line agent for septic shock.
It provides potent alpha-1 agonism to constrict arterioles, plus just enough beta-1 kick to support heart contractility.
What MAP target are we titrating to?
For most patients, a mean arterial pressure of 65.
Because that's the threshold where vital organ autoregulation kicks in.
But the 2026 guidelines introduce a fascinating shift for older adults.
Yes, targeting a slightly lower MAP range of 60 to 65 for adults over 65 years old.
Why accept a lower pressure in an elderly patient who might have chronic hypertension?
Based on the 65 trial, older patients are way more susceptible to adverse effects from high-dose catecholamines.
Pushing norepinephrine just to hit 65 might trigger atrial fibrillation or myocardial ischemia.
So accepting a MAP of 62 might actually be safer. It's balancing risks,
And logistically, we used to think you could only run norepinephrine in through a central line.
which was a nightmare. Losing precious hours trying to place a line while the patient's brain and kidneys are dying.
The guidelines are explicitly clear now. Start vasopressors peripherally to restore the mean arterial pressure immediately.
You do not wait for a central line.
But what about the fear of extravasation? Tissue necrosis.
Modern evidence shows that with a large bore peripheral IV and strict nursing protocols, the risk is incredibly low.
And we can reverse localized vasoconstriction with phentolamine anyway.
Exactly. The minor risk of a temporary IV complication is outweighed by the absolute certainty of anoxic organ injury if you wait 2 hours.
The guidelines also endorse a hybrid approach for severe unstable shock.
Meaning you simultaneously initiate early concurrent pressors along with that initial fluid bolus.
Because early norepinephrine squeezes the massive venous capacitance vessels, pushing pooled blood back to the right heart.
It acts like an intravenous fluid bolus on its own.
Okay, so the peripheral norepinephrine is running, but the doses are climbing. The MAP is still dropping.
You don't just keep turning the dial up until their fingers turn black. You add a second agent.
The guidelines strongly suggest adding vasopressin early, usually around 0.2 to 0.3 micrograms per kilogram per minute of norepinephrine.
Why vasopressin?
Receptor diversity. Severe inflammation depletes the pituitary stores of endogenous vasopressin,
So replacing it stimulates the V1 receptors in vascular smooth muscle.
a completely different pathway than catecholamines, which is brilliant because acidemia often desensitizes alpha-1 receptors to norepinephrine.
It exerts a massive catecholamine-sparing effect, protecting the heart.
But what if shock is refractory? Max norepinephrine vasopressin is running, MAP is still 50.
You add your third-line agent, epinephrine.
But we have to warn people about the physiological catch with epinephrine.
Ah, yes, the lactate bump.
When you start an epinephrine drip, the lactate level will almost inevitably skyrocket. Residents panic, thinking the bowel is dying.
But it's usually not worsening ischemia. Epinephrine powerfully stimulates beta-2 receptors on skeletal muscle cells.
Accelerating the sodium-potassium pump, driving a surge in aerobic glycolysis.
The mitochondria can't keep up, so excess pyruvate shunts into lactate production, even with adequate oxygen.
It's a metabolic phenomenon. You treat the patient, not just the lactate number.
What if the patient has a normal blood pressure, but their extremities are ice cold? An echo shows sepsis-induced cardiomyopathy.
Squeezing the pipes tighter with alpha agonists just increases afterload and makes the stunned heart fail faster.
So the guidelines suggest adding a pure inotrope, specifically dobutamine, to your norepinephrine infusion.
Or just switch to epinephrine alone for both pressor and inotropic effects.
And what about oral midodrine? Lots of folks use it off-label to get patients off tiny doses of Ivonor and Turatifrin.
Hoping to bridge them out of the expensive ICU bed.
The guidelines formally state there is insufficient evidence to recommend routine use of midodrine yet. We need more trial data.
Okay, so hemodynamics are relatively stabilized. We have to look at adjunctive therapies.
The most enduring controversy, corticosteroids.
We swing back and forth every decade on whether they save lives or cause massive harm.
The 2026 stance is pragmatic. Corticosteroids are definitively not for every patient.
We only reserve them for patients in refractory septic shock.
Right. If norepinephrine requirements stay greater than 0.25 despite adequate volume, initiate intravenous hydrocortisone.
The goal is to treat critical illness-related corticosteroid insufficiency, replacing the deficit from the overwhelmed adrenal glands.
And exogenous steroids powerfully sensitize the alpha receptors to our vasopressors,
Making the norepinephrine work better, getting them off pressors faster.
Now, half of being a good critical care doctor is knowing what not to do. The guidelines provide a graveyard of therapies.
Number 1, intravenous vitamin C.
The vitamin C saga. The Lovett trial showed absolutely no mortality benefit and actually suggested a signal of harm.
Because massive ascorbic acid metabolizes into oxalate crystals, actively worsening acute kidney injury.
Next, they suggest against using intravenous immunoglobulins for routine sepsis.
It carries massive financial cost and risk of fluid overload without improving broad outcomes. What else?
They explicitly suggest against blood purification techniques, like polymyxin B hemoperfusion.
The Euphrates trial showed selectively filtering endotoxin just didn't translate to a mortality benefit.
Finally, they firmly advise against using probiotics.
Giving live bacterial strains to profoundly immunocompromised patients has actually caused probiotic-induced fungemia. Just too dangerous.
For general ICU care, stress ulcer prophylaxis with PPIs is suggested only for patients with established GI bleeding risk factors.
And for respiratory support, if they don't need intubation yet, prioritize high-flow nasal cannula over standard oxygen.
It flushes dead space, provides a little PEEP, and is heated and humidified.
But target a conservative oxygen saturation of 90–96%. Avoid hyperoxia to prevent oxidative damage.
Zooming out, what strikes me about these 2026 guidelines is how they validate clinical intuition.
We are moving past the unthinking checkbox era. Sepsis is dynamic. The treatment must be dynamic.
It requires vigilant reevaluation. You give a fluid bolus, then assess the stroke volume response.
You start a broad antibiotic in hour 1, but proactively de-escalate at 48 hours. Precision medicine.
Delivering the exact right therapy to the specific patient at the optimal moment.
Let's run down the bottom line. What should our colleagues actually do differently on shift tomorrow?
Point 1. Do not reflexively give 30 milliliters per kilogram of normal saline to everyone.
Adjust for ideal body weight, use balanced crystalloids, and use dynamic testing before giving more.
Point 2. Master the antibiotic matrix. Treat within 1 hour for shock.
But use the safe 3-hour window for diagnostic clarity if shock is absent.
Point 3. Use prolonged infusions for beta-lactams after a rapid loading dose and de-escalate early.
Point 4. Start norepinephrine earlier via peripheral test if needed to restore MAP immediately.
Point 5. Add vasopressin early when norepinephrine doses climb, sparing the heart from toxicity.
Point 6. Treat sepsis as a complex individual physiological puzzle, not just a bundle.
These thoughtful shifts are exactly how we improve those staggering global mortality statistics.
Think about that the next time you face that terrifying diagnostic uncertainty. This episode is for educational purposes only and not medical advice. The voices are AI-generated,